Hello, welcome. Today is Wednesday, September 9th. My name is Gordon McNeely. I'm the chair of the Standing Committee on Health and Social Development. I would like to just welcome committee members here: Heath McDonald, Sydney McEwen, Jamie Fox, Hannah Bell, Trish Altaz. And so we're going to receive a briefing, but before that, can I have a motion to adopt the agenda? Jamie Fox. So we're excited to get a briefing on how the pharmacists have been managing during the COVID-19 pandemic and plans going forward as we enter flu season. So without further ado, I'm going to pass it over to our guest to take her time and introduce herself, and for the record, and just you can continue on, or you can start off with your presentation.
Super, thank you very much. So my name is Erin MacKenzie. I am the Executive Director of the PEI Pharmacists Association and also a practicing pharmacist on Prince Edward Island. And I'm very pleased to be able to come today to present to you a little bit about kind of the impact that COVID-19 had on pharmacies and pharmacists as the pandemic came to Prince Edward Island. And also to maybe talk about some of the lessons learned and provide maybe some perspective on where we see things might be able to be improved moving forward to be better prepared for a second wave or resurgence of the pandemic in the province. So just to kind of get started, and I think I'll try to keep this a little bit informal, if you don't mind. And if there are any questions, if you want any kind of clarity around some of the points that I'm raising, I'd be happy to provide that. This is really, you know, just kind of a story that I'd like to share with you, and the points on the PowerPoint are really just to kind of keep my thoughts in order here. So I guess to start off, I'll say that hindsight is 20/20, and some of the things that you'll see throughout this presentation that pharmacists have been raising and solutions that we have proposed throughout the course of over the past more than a decade have not changed. I think that maybe the COVID-19 crisis served to illustrate the importance of many of these proposed initiatives and brought them to light. So even prior to COVID-19, pharmacists have been advocating for better utilization of their services and have advocated that by using pharmacists to help deliver frontline healthcare services. Am I feedbacking here? Yeah. Try that. Sorry about that.
Oh, no worries.
We know that if we better utilize pharmacists, we can help to keep non-urgent complaints from overcrowding our emergency rooms. There have been reports of people going to the emergency room to get refills on the prescriptions, for example, because they can't access a family doctor in a timely manner, or get common or minor ailments assessed and treated at an emergency setting, whereas pharmacists are certainly well positioned in their communities to do that. Improving access to walk-in clinics, reducing wait times for physician appointments, and reserving our highly skilled physicians for more complex cases. But that does require a modernization of pharmacists' scopes of practice, and also enable services provided by pharmacists to be included within a publicly funded model. We can't have a situation where to reserve the service from one provider, you're covered under the provincial program, whereas getting those same services offered through pharmacies have to be paid out of pocket. It causes quite a barrier. So I'll just kind of tell you a little bit of a story when we first heard the news that the pandemic had been announced, and Health PEI largely moved into their pandemic response. We saw many non-urgent Health PEI services being suspended. Many of the walk-in clinics and physicians' offices were closed unless there was an urgent case or an emergency case. And some of those did not come back until there was a good plan in place for physician billing numbers and virtual care. Pharmacists, however, were there on the front lines from the beginning, and they remained steadfast in delivery of frontline health care. So especially at the very beginning, we were inundated with referrals actually from other healthcare professionals. Go out, talk to your pharmacist if you need assessment for minor ailments or treatments for minor complaints. People that are looking for continuation of immunization services or injection services often couldn't get them from their traditional physician's offices and so on, or nurse practitioner, because there was no one in those offices. We saw a large number of patients coming to us looking for refills on their chronic medications. Now, pharmacists by law can assess and prescribe if deemed appropriate to continue chronic medications for people so that their therapy isn't interrupted. Unfortunately, there was no reimbursement structure around that, so pharmacists were being inundated with requests to meet and assess patients to continue therapy. And actually, referrals were coming from clinics and from the Chief Public Health Office as well. We provided recommendations on innumerable health concerns and triage as well, as patients didn't want to go to emergency rooms. They were afraid of COVID, and they didn't want to expose themselves if they didn't have to. And so they came to pharmacies, not only to kind of get some of the less urgent care situations looked after, but also for that triage. Do I need to go? What is your recommendation? COVID-19 questions, as you can imagine, were through the roof. Everything about what does this mean, what are the impacts, what symptoms should I be looking for, and a lot of screening was done at the pharmacy level. At that point, calls to 811 were not being returned in a timely manner. It was very difficult to get through to that service. So pharmacists were there on the front lines providing it. And the other thing that we did was we really, took the Chief Public Health Office recommendations to heart, trying to keep everybody home. At this point, we didn't know what we were dealing with. We didn't know if we had community spread. And it was imperative that we tried to keep as many people home, isolated, as much as possible to try to control the spread. So a lot of pharmacies began offering delivery services, some that didn't offer it before, but others who already had it in place increased their delivery by at least 200% in a lot of cases. And some actually did renovations to allow for a drive-through or a curbside service to keep people from coming into the pharmacies in those crowded spaces. Remember, most people that are coming to pharmacies are ill. I shouldn't say most, but a lot of them are ill or chronically ill or are at high risk. And so it was imperative that we kept those vulnerable populations protected. These, of course, all these services were offered, I guess, in the heat of the moment to make sure that we looked after the crisis at hand, got that patient looked after, and quite frankly, worry about how we were going to pay for it later. You can imagine the increased costs associated with protecting the public and delivering that level of service. So on top of the situation at hand, there were some other issues that arose that I'm sure most of you have heard quite a bit about. One being drug shortages. Now, drug shortages are something that pharmacists live with on a daily basis, and that is something that we've seen more and more as the federal government, in concert with provincial governments, have looked at generic drug pricing reform. We've seen much less options in the generic drug field, so we do have fewer options. If there is one product that goes short from the manufacturer, for example, there are much fewer generic options out there to choose from, as the pricing on generic drugs has been devalued. And that's a whole other topic of conversation. So certainly that continued to play a role. There was a small amount, I guess, of panic buying. People were being urged to stockpile up a couple months' worth supply of their medications. Now, in the larger global drug supply world, Canada is allocated a certain amount based on projections of what they'll require to meet the needs of their citizens. And you can imagine if everybody decided that they wanted to stockpile 3 to 6 months just in case they don't know how long they're going to be home, what that would do to that drug supply. And we saw that very, very acutely. And also, people who maybe weren't as compliant of getting their refills picked up. They may keep an inhaler on hand, for example, just in case they had a flare-up. The unknowns made people be a little bit more aware of what they may require. So a lot of those fills were being requested, and there just was not the drug supply in the system. And that, not necessarily from manufacturer level, but there are so many different levels of supply chain issues that can occur. If there are restrictions on travel, for example, or shipping, those types of things really impacted the supply as well. We also ran into difficulty in accessing personal protective equipment, or we refer to it as PPE. So there was not, a consistent supply of some of those things, such as hand sanitizers. We couldn't even keep hand sanitizers or rubbing alcohol on the shelves. Some pharmacies couldn't even get it for their own use. Accessing masks and gloves and those types of things was quite problematic, particularly at the beginning of the pandemic. Certainly with the demand, manufacturers did try to step up and produce more, but at a premium, and the cost for that type of supply certainly increased. We also saw a change in our operations to deal with the pandemic. And just as one example, a lot of pharmacies had to move to a team-based scheduling model. So if you have 3 pharmacists working in your particular location, you can't necessarily have them overlapping. If one team member goes down, that entire team has to self-isolate for 14 days. So we had to separate our teams, and because of that, often limit the hours that pharmacies were able to be open to serve the public. So it made it quite challenging, making sure that there would be a pharmacy team there ready to serve the public, while making sure that there was no cross-contamination of the teams, if you will. I also mentioned the delivery and curbside service, which was a huge addition to what pharmacists were already doing. And when you have increased costs to deliver a service in a regular retail world that's not a health profession at the same time, what do you do? Well, you increase your cost to deliver that services. We could not, in one side of our mouth, say you're not allowed to come into our pharmacy, you have to stay home, and then say if you want us to deliver your medication, you have to pay for it. So pharmacists did the right thing. And again, on our reflections, we're trying to figure out a way that we can continue to do the right thing and be sustainable in doing so. There were some regulations, both federal and provincial, that cropped up again that we had been looking to change for various reasons anyway, but they did result in some difficulties in serving the public. And some of those were addressed particularly through a Health Canada directive to change some of the regulations regarding controlled and narcotic medications, so being able to extend those, and that was done at a federal level and adopted mostly by our province as well. And there's policies that limit access to care in this province, and they're pretty much policies that, for example, allow patients to access the smoking cessation program through pharmacies, and a pharmacist can assess and prescribe for smoking cessation. However, policies limiting access to that program unless you go through an intake site specific at some of the provincial health centers through a nursing staff, patients could no longer get access to that program. So they were left kind of in the lurch, and we had been advocating to improve access by getting rid of that barrier anyway, but some of these things just really came to light when that other option wasn't there at all. And of course, as I mentioned, during all of this, and we had been in touch with government on a few occasions via email and letters to say that, we're doing this, we need help, and we do need to discuss remuneration model definitely going forward. So some of the lessons learned, COVID-19 has presented an opportunity to innovate and modernize our healthcare system. We see that engaging pharmacists builds capacity in the healthcare system, that current remuneration models need to change to support pharmacist services, to remove that barrier of having to pay out of pocket for the same service from that healthcare professional. Pharmacists must finally be enabled to practice to their full educational scope. And I think a lot of you in this room have heard this presentation before, because it certainly is not a new ask. Regulations need to be modernized and specifically to expand virtual care. And we're hopeful that we are making some movement on that with our regulatory authority because, for example, if you had someone at home that needed a refill on an inhaler, for example, unless that person could come in and see me, I have to provide that service in person. And really there's no need for it. The questions and the assessment for some of these things can be done virtually over the phone. And we just need the regulations tweaked to allow that because currently they do not. And government policies limiting access to programs through pharmacists must be lifted. So I mentioned smoking cessation program. Another really good one is vaccinations. So certain vaccinations that are covered provincially, such as pneumococcal vaccine, are only covered by the province if they are accessed through public health nursing and perhaps physicians' offices. I'm not entirely sure on that. But if you wanted to get them through the pharmacist, we can't bill for them. So we have to improve vaccination rates. We know that. And removing some of these policies that limit access have been suggested before and again became extremely acute during the COVID-19 pandemic. So really what pharmacists are feeling and seeing, I guess, is a missed opportunity. Pharmacists at the beginning of the pandemic were exhausted. All of us were exhausted. We were, being inundated with the new normal of trying to figure out on the fly how to meet the needs and the demands of patients and how to change our delivery models to comply with public health directives and keeping people safe, keeping people home. When we hear about things such as, the great recruitment campaign that you're seeing on social media and other media that the province has undertaken through Health PEI, targeting health personnel, offering to pay for people to come out of retirement and so on. The pharmacists couldn't help but feel, we've been here since the beginning of this. We have over 150 practicing community pharmacists in the province. That's over 150 additional healthcare professionals that are already in the province to provide a lot of these services. We also have 49 additional primary healthcare centers and pharmacies. You can notice on that map, there's a couple in red and there's one in a -1. So when I first was wanting to put this presentation together, we actually had 50. We did have one pharmacy close. The business model just does not support, I guess, the service demands when there is no reimbursement model attached to it. When pharmacists heard that, the province had contracted Maple to provide services, it was quite disappointing, I think, for a lot of pharmacists. These are the things, and if you check the website, some of the things that are being recommended to be managed by Maple, which is the virtual care platform that the province announced. A lot of those are targeting the exact common ailments and minor ailments that pharmacists have been looking to provide under a reimbursed model for years. And it was quite disappointing that pharmacists weren't engaged and absorbed into the healthcare system to try to build capacity. The other, I guess, thing that was a little bit frustrating for pharmacists was the announcement that, I think the compensation package that had been offered to physicians worth, I believe, $2.3 million to ensure that their billings were not impacted due to COVID-19. I heard from many pharmacists who were just so disappointed. We were there providing the service. We did not close our doors. We stayed there, and, you know, it may sound a bit dramatic, but, you know, at the time we had no idea what this meant, whether the community spread was going to be, you know, impactful here. You're going to work literally trying to distance yourself as best as you can with limited PPE, doing your best to keep yourselves, your staff safe, going home, stripping off in your garage and running through the shower, hoping you're not bringing that home. So pharmacists were emotionally tired. They were not feeling very appreciated when we hear that there was no funding in the model to look after the patient in front of you, even though you stayed there throughout, maybe perhaps putting your own self and your family at risk. So this slide actually has probably been in every presentation I've given over the last 12 years, and I just put it back there because it's just so poignant. We are the very first point of contact to primary care for patients in the community. And we are doing things like prescribing and treating for minor or common ailments such as cold sores, allergic rhinitis, which is going to be very, very important, particularly in the coming months. Providing smoking cessation counseling and support, chronic disease management, vaccinations other than flu shots, management of the drug information system, triage and telephone advice on self-treatment, and some of the other services to ensure patients have access to their medications. And none of these services mentioned, although are very valuable to patients, are reimbursed by any kind of model. So next steps, how can we be better prepared? I think that it's very dangerous for us to be complacent, even though we've been very fortunate in Prince Edward Island under the capable leadership of Dr. Morrison. We really have to make sure we're on our toes, and we can't think that we're going to be spared by a wave of COVID-19. Some of the other provinces, and I'll just give the Nova Scotia example, they invested in pharmacist services to build capacity in their healthcare systems early on in this pandemic. So this was around, I think it was March 18th or 19th that this announcement was made. For example, they engaged pharmacists to ensure the continuity of care for patients who were impacted by prolonged drug shortages by expanding therapeutic substitution eligibility. And what I mean by that is, if there is a drug shortage, and sometimes it'll be just one particular drug, but sometimes it can be an entire class of drug. So if you're being treated for something, say for blood pressure, and we did see this happen, a drug called valsartan was short from the manufacturer, could not get it. So the first thing that would happen would be, is there another drug within that same class that we can switch it to? Sometimes that can happen, sometimes that can't, and sometimes we have to go outside of that class and identify a drug option that would in effect have the same expected benefit to that patient and be compatible with their other medications. Pharmacists are the drug experts, and that's what we do. So sometimes physicians will call us and say, what can I give? This is short, what would you recommend? But pharmacists can actually do that themselves without having to send that patient back and have to see their physician to make some of those decisions. As you can see, it's not as simple as just striking your pen. It does take quite a bit of a individual patient assessment, and it is a professional function. We have approached government to reimburse for that type of service because it is time conserving, and it does require that pharmacists take that responsibility and liability on themselves. Nova Scotia did expand theirs slightly in the spring for that very reason. Nova Scotia also provided at the beginning of the summer a 90-day supply for all their pharmacies for PPE. So if they did require it, they could get that provided through government in a 90-day trial, and I have not heard whether that is going to continue into the fall. But it certainly was a help. The costs that are associated with making sure that you keep patients, especially the vulnerable that are coming into your pharmacies, masked and distanced, and make sure that there are regular cleaning schedules in the common areas and in the private counseling areas and so on, is crucial. And the cost associated with providing that on top of everything else has been phenomenal. I spoke to modernizing regulations to allow for virtual care. Nova Scotia did take some steps in that direction as well, to kind of ease up on some of the restrictions to make sure that people were seen when and how they needed to be seen. They also removed some of the policies limiting access to provincial health programs, and the one that I recommend here certainly is access to that smoking cessation program for people who can no longer see that nurse because they have been reallocated for COVID measures. And also fair reimbursement for the services being provided. Nova Scotia early on, and actually this was under, it was in the works before COVID, but they kind of fast-tracked it. They do reimburse pharmacists for doing that assessment and extending refills. You're saving that patient from having to go back for a costly medical appointment or going to the emergency room with your little bag of medications that need renewed. Pharmacists can do that, and they are being reimbursed for their time and for their professionalism in doing that. So I think I'll, if it's all right with everybody, I'll continue on with preparing for flu. Did you have a question?
If you want to have a drink, you've been talking.
I know.
Or just have a little drink, and maybe we'll just give you a second.
Yeah, sure.
Doing a great job, and we'll take a few questions at this time.
Sure, absolutely.
Okay. Hannah.
Thank you, Chair. Thanks very much. I do recognize parts of the presentation. Repurposing is good. We like recycling. It's unfortunate, though, that you are having to repeat the same messages, and particularly in light of, as you said, the additional role and pressures that are there. You know, obviously a common thread in this is about the remuneration, a word I find difficult to say. Could you speak a bit more about that, you know, because I get that, you know, you've talked about sort of like, here's all the other things that we do, and so what kind of does that gap look like in terms of how you actually are sort of being remunerated now?
Sure.
And oh my gosh, that's so hard.
It is hard.
Yeah, and what that could look like, you know, and what impact would it have?
Well, currently the business model is very antiquated. We haven't had a new contract since, I believe, 2012. So back in those days, scope of practice for pharmacists hadn't evolved to the point it is now. And in 2014, we were successful in getting expanded scope to allow, for example, for administration of flu shots, which was a huge success story. Pharmacists now giving approximately, well, over 60% of those flu shots administered in the community. And I'll talk a little bit more about that in a moment. But reimbursement for pharmacist services is something that we have been looking for since they've been introduced. The old model is basically a model of reimbursement for product. So what we've done is we have reallocated staff. We have advocated and we're successful in having pharmacy technicians regulated so that they can do a little bit more of that technical, they used to call lick, stick, and pour. So making sure that, you know, that the right product is in the right bottle, but still having the pharmacist there to do the clinical check to make sure that that product is the right product for the patient, the condition being treated, the right dosing, no drug interactions, and so on. But by being able to bring in some other support staff, we've been able to free up the pharmacist to provide some of the other services that we, you know, that the reason we went to school in the first place, basically. So that is to do some of these minor ailment assessments and prescribe for medications. In Alberta, they've been enjoying a full scope of practice for, I believe it was 2008. And they've really worked in a collaborative type of a situation whereby pharmacists, for example, if your physician who is your expert in diagnosing diagnoses you with diabetes, the patient can go into the pharmacy. Pharmacists will check on their blood sugar readings and their A1C readings and say, you know what, your medications are just not, you know, where they should be. And pharmacists can adjust those medications or add new medications to make sure that the patient is being treated with the best possible medication program for their condition. So they can do that independently. In PEI, unfortunately, we're quite a long ways away from that, and we have been pushing for that since 2014. But there needs to be a remuneration model attached to that. So now that we've freed up our pharmacists to be able to do some of this work, which we feel is huge in filling some of the gaps in access to care, we do need to have a model in place that supports hiring those pharmacists to be there and to be on site during those hours to provide those services. And we know there's value in them. If you went to your physician's office and looked for a refill on your prescriptions, they're going to do an assessment and they're going to refill your prescription and they're going to bill for that service. Same for any of the other services that we've mentioned. There is value already established in these services. Other healthcare professionals are reimbursed to provide them, and pharmacists should not be asked to do that and figure it out themselves to provide that service. We've been hearing for a long time that there is a shortage of physicians. There's a major, there's trips being taken to try to find physicians that will come to PEI. There's trips being taken to get some nurses to come back from Alberta to come and work in PEI. We have healthcare professionals here that we're not investing in that could absolutely take some of those pressures off of those other frontline healthcare professionals. Simple things as improving access to adult immunizations by being able to build a system rather than charge the patient out of pocket for some of these recommended vaccines, and doing those assessments for the common ailments in New Brunswick and Nova Scotia, and we do believe finally, we hope that will come here as well, but the assessment treatment of urinary tract infections. We're also looking for the ability to assess and prescribe for contraception. Some of these things that certainly are within the pharmacist's scope to assess and diagnose and prescribe for could be done more accessibly in the communities, in those 49 centers of healthcare right across the province. If only there was a model that was developed that we could work with other healthcare professionals and with government to make sure that patients have access to those services.
Anna?
Thank you for that. Obviously, lots in there, but there's a couple of really key things in there. One of them is about building capacity with what you have, and we talk a lot about when we look at sort of the recruitment and retention models. It's way easier to retain and build capacity than it is to try and kind of create new faster into the ground. You've already got people who are connected into the community, so that scope of practice is something that we've spoken about a lot, sort of, from our side of the house, and just generally, it's a bit of it is a no-brainer. It doesn't make, it seems like a really obvious solution. It's obviously not a be-all, but it fits into the continuum, and it's about sort of fitting into the space that we have. Obviously, the success of the flu vaccination is a really good example, and I'm really pleased to hear you mention the piece around contraception and UTI in particular, because from a women's healthcare perspective, those are some of the ones that, again, I'm familiar with from other systems that can have a real impact in quality of care and in access to care for communities that otherwise may not have that, particularly where we're challenged with the lack of GPs and that kind of gap in our system. When it comes to sort of that scope of practice and the associated things that come with that, there's a couple of pieces in there. One of them is I am really concerned about the idea that we've contracted another party who external to fill a space that, without checking that we actually have that skill set here already, seems really counterintuitive and frankly very concerning. The other piece is, to my mind, this feels like this would be a much more cost-effective space. So I'm really wondering, where are the barriers? And are the barriers political? Are the barriers legislative? Or are they bureaucratic barriers? Is this a matter of we don't want to change because this is how it's always been? And I'm wondering, I know that's a tough question, but I'm guessing you might be able to help.
Well, and you know what, those three that you have just raised certainly would be the top three, I would say. We have to look at new ways to solve old problems, and I think I've demonstrated these are old problems. It's been over a decade for us that we've been looking to share what we can offer, and we've seen our colleagues in Alberta offering them since 2008. So absolutely, I think there is a certain amount of this is the way things have always been done. I did actually try to engage with our deputy minister to draw all the parties into the same room. Because sometimes when you're trying to figure out what are the barriers, well, you get a little bit of, well, a he said, she said kind of situation. So he was great to do that, to enable that. And we had representation from government legal, the bureaucracy, the deputy minister, our college, our licensing body, and myself. We had a couple meetings. COVID struck. We didn't get much past January, unfortunately. But these are some of the things I think that we really have to focus on. What are the barriers? Let's get them out there. Let's discuss them. We can solve this. And again, we're not the be-all and end-all, but we certainly are, you know, we tick a lot of the boxes. Access to care in the communities that you're trying to serve. Lack of healthcare professionals, well, there's over 150 of us in the communities that aren't being used. Let's see if we can find a way to make that work finally. And you know, we certainly have the support of Canadians and Atlantic Canadians. Last April, there was a study released by the Canadian Pharmacists Association that actually showed that 93% of Atlantic Canadians strongly believe that pharmacists, you know, are completely prepared and educated and have the skill set to deliver these services and to do more.
Annabelle?
Thank you. Sort of one of the areas that I can specifically focus on is around the policies that are limiting access through some of the health programs. I know you mentioned something like smoking cessation, which initially may not feel, you know, as urgent as somebody with a UTI, for example, but that we know that in terms of our kind of primary pressures on a healthcare system, that's one of the areas that we absolutely need to ensure that we continue to provide support, and it is something that requires that relationship and so on. And so it seems, you know, again, looking at this at a very high level, but that is very much about a policy change that just says, you know, we're removing a barrier that doesn't need to be there. These are about barriers that are there because that's the way they've been. One of the things we've learned in COVID is how when we really need to, we absolutely can pivot and change, and how it was before. Not only is we can unpack it and do something different, but we shouldn't be going back. Right. And so, you know, one of my concerns, have there been, you said there were some things that were done on a temporary basis because of this being in COVID. Have you had any indication any of those are going to be able to be made permanent? Is that sort of one of the potential first steps that we could look at, is entrenching some of the things that you've been allowed to do in the interim?
Well, the larger, I guess, considerations that were changed were done at a federal level. So the jurisdiction for controlled substances and narcotics is federal. So, you know, where that'll land, I'm not sure. We've actually, on a national basis, been looking to get some changes made federally to those legislations that restrict pharmacists from changing or altering narcotic and controlled prescriptions. So it would require pharmacists to be able to prescribe for these. People immediately think, well, we already have a opioid crisis. Why do we want more people able to prescribe for these drugs? But pharmacists don't want to introduce more drugs into the system. What we want to be able to do is de-prescribe, which means if I want to, you know, this patient's been on a drug dosing, and help them wean down off of it and get to something that's a little bit less problematic, for many reasons. So that's a whole other story. But some of those, certainly, they have been, we have been advocating for those nationally. Provincially, some of the little changes that were made, such as being able to, you know, it's just basically little procedural things about how I can transfer a prescription from one pharmacy to another. You know, it makes my life a little bit easier. It's not hugely impactful for patients, but, you know, there are certainly some regulations that are outdated that need to be addressed. And virtual care certainly is a big one.
Cool. Thank you very much. Trish?
Thank you, Chair. Just building on the discussion around the Maple Virtual Care app and the introduction of that service here in Prince Edward Island. So, building on what my colleague mentioned there, I guess I wonder about, you know, in your presentation you mentioned one pharmacy closing, and just that the government has chosen to contract out services to an off-island company rather than looking at what can be provided here by our healthcare professionals such as pharmacists who could provide similar services. So I mean, I guess first of all, you know, when we see that one pharmacy is closed, I'm wondering, you know, are other pharmacies approaching a place where they're not going to be able to sustain their business model with the current additional pressures that have been added?
Yeah, certainly. I think margins were running pretty thin anyway. There's been a lot of price cuts as far as, you know, generic drug reform, and, you know, that's fine as long as, you know, there is another kind of an offsetting balance there and paying pharmacists for what they're actually doing now. So, for example, some of our pharmacies, there's 2 locations on that little map that were in red. They've now gone to maybe a 3-day-a-week opening because they can't sustain an opening of every single day. And, you know, why is that? We're busy. Why is that? Well, the reason is pharmacies and pharmacists provide a different service than just dispensing medication. The seniors that in Morel have been coming to the pharmacy owner and saying, you know what, we want you here every day. They come in to see their pharmacist for all of those things I mentioned, for checkups on their chronic disease management, for advice on minor ailments, for extension of their prescriptions. So all of these very important resources, and sometimes the pharmacist is the only healthcare professional in that area, and people have comfort for having that resource there. And I think it serves a very important purpose to make sure that people do have access to a healthcare provider, not necessarily an 811 that's being serviced out of Nova Scotia, that you don't know the patient, you don't know the story, you don't know how to manage that patient. And, you know, I could argue that Maple would not be much different from that, in that I know this patient. I've been dealing with them and their spouse and their children and their health conditions for the last 15 years. And they come to me for these health questions and to manage some of these conditions. And I'm well positioned to do that. And I have a keen sense not only of the patient, of their support systems at home, and of, you know, their other factors that may impact their health. You know, and when we look at the virtual care, and I just kind of did a screenshot of the government website that talks about what will the virtual care offer. And the most common conditions successfully treated through Maple virtual care include cold and flu, eye and ear infection, minor allergic reactions, minor injuries, urinary tract infections, sexual health, and so on. These are the things we've been asking for since 2014 and before.
Trish?
Thank you, Chair. And so you mentioned that you had reached out to government on a few different issues and didn't get response back. Would this be one of those issues then that you reached out to us? Have you received any clarification on what the difference is between services provided by Maple and what could be provided by pharmacists? No?
No. Okay. No.
I want to just shift quickly to PPE. So you mentioned early on in the pandemic that you pharmacists were struggling to have enough PPE, and they were falling short, not being able to meet that requirement, and that in Nova Scotia they were provided with a 90-day supply. I mean, I find that quite concerning. So where's, you know, obviously I'm assuming this is something else that you reached out to government about, and were there any, did government provide any sort of supports around PPE? Was there anything accessible, any sort of stockpile that you could access?
Yeah, so I guess the way that it was managed here, so this all happened in real time on this like fast train, and we're trying to, you know, communicate as we go. You know, via email, via quick letters. We're dealing with this. We need to address this now. This is crucial. We have to figure out a way to support our pharmacists, to support our pharmacy staff, and certainly PPE was one of the big asks, along with, you know, some sort of remuneration model, because we had one pharmacist on the phone an entire shift, just dealing with you know, refill questions and COVID screening and all of these things, and the rest of the work needed to get done, but there was no reimbursement for that. So basically, we were looking for all of this. PPE was a big one, and as far as PPE goes, We were successful in being added to the list of essential workers that would have access to it if we could not access it ourselves. So we were pleased with that. However, really when you're dealing in a healthcare setting, particularly when we're moving into flu shot season and it's impossible to maintain a 6-foot distance unless you're a really good shot with that dart to immunize someone. So it's going to be very, very important that there's adequate supply and people feel safe to come and get their flu shots, and I'll get into that. But certainly the push has been on to, we need support on this. If we have a stockpile and you have maybe access to sources that we don't, like some of our pharmacies are paying like the exorbitant costs for this stuff. They're getting it online. They don't know what they're getting. They're ordering it, for wherever they could try to find some in the beginnings. That seems to have settled down because we did see some more, like some of our local companies making hand sanitizers and that type of thing. And, there may be a little bit more in the system, but certainly the costs are just over the top for pharmacies. And so that was why, as a show of support for pharmacists who are providing a lot of those healthcare services that are no longer being provided from physicians' offices, clinics, and NPs due to redeployment for COVID priorities. That would be why Nova Scotia gave the offer of a 90-day to see if they could assist in that manner.
Mm-hmm. Okay, thank you, Chair. And just quickly, I think that it's this piece of recognizing pharmacies as a healthcare setting, as you say, because it's part of our healthcare services in that many people can't go without their medications. It is critical. So just when you start to look at it through that lens, we realize the value of of what pharmacists bring, and then the additional value that could be brought if we were to look at what you could do in terms of your full scope of service or practice. So, so I think this is a very valuable discussion today. Just one last question. I wonder if there's any data available that you know of on the uptake rates in Nova Scotia when they allowed pharmacists to provide refills of prescriptions. I'm wondering if that had a significant impact on the rate of that happening.
Yeah, and to be fair, I have not seen any numbers, and of course, everyone is still shaking their head thinking, what just happened? So they really haven't had an opportunity to kind of do that evaluation. I am involved in a research group through Dalhousie University, and I'm starting to see more and more kind of studies and evaluation about what happened, and I'm hopeful that we're going to get some of that information when things settle down.
Great, thank you. That's all.
Perfect, thanks. Heath McDonald?
Yeah, just something that I just want a clarification on. Something you stated earlier is more so than a question, but it was relevant to the opioid use. And say, if someone went in to fill a prescription, if I understand this, and you decide that slowly you can diminish that prescription for that person, is that that's not taking place now? So the opioid users are going through the door, they're getting a full prescription every month, even though they may not be able to see a doctor or a nurse practitioner, whoever, a counselor or whatever, to have that prescription decreased? Is that kind of...
Yeah, I mean, there's lots of reasons why we may need to decrease someone's opioid medication. So it may be that the patient comes in and they're having side effects, secondary effects due to opioids, which is extremely common. Or it may be that that person is elderly and it's not recommended in that age group anyway. Certainly, sometimes, narcotics are required to treat pain. We can't have patients in pain. But a lot of the times, people maybe are on them a lot longer than they need to be, or their dosing is such that they could have gone to a long-acting rather than the short-acting, feeding your pain every 4 hours. There's better ways to manage pain sometimes, but it does require a healthcare professional to work with that person to find that sweet spot, to find that dose, and sometimes to get them completely off of narcotics or controlled medications. So a really, really good example of this is benzodiazepines. It's a drug class that's used to be used handed out quite freely, and it was used as a sedative, it was used for sleep, it was used for nerves, it was used for lots and lots of things. And a lot of people were prescribed that when they were, particularly I think it was quite popular in the 70s, and then we're finding these people that were taking it in their 70s are now seniors, and the medication should not be used in seniors. It's actually toxic to the senior brain. So to try to get people weaned off of that is quite problematic. I cannot work with that patient to wean them off, because for me to change or alter those types of prescriptions, that's considering that I'm now the prescriber. I didn't initially initiate the original prescription, but I'm in that context the prescriber, and I can't prescribe for those types of medications. So some of those regulations we know and legislation has to change on a national, federal basis. So that's why nationally we've been looking for that to occur.
Heath?
It's interesting, just with everything that's happening in BC and what they're trying to do out there, it was kind of something that was...
to the access point as well, I mean, when we talk about access and limitations on policies, other provinces allow pharmacists to provide, dispense naloxone and training for naloxone through pharmacies. This province has chosen not to go in that direction. So they make it available through addiction centers and some of the community health centers, and there is a spot on the website that shows you everywhere, but community pharmacies aren't included on that list, which is unique to some other provinces have gone the route to have it in the communities accessible to help save lives.
Heath?
I may be getting ahead of myself or ahead of you here on this, but I wanted to ask about flu season coming up. Last week we had Dr. Heather Morrison in, and we talked a little bit about it, and we talked about the resources around that, and if they were going to be able to expedite flu season, the shots, and she kind of said that's what they were working on now. So I guess I'm curious in relevance to if there is a vaccine along with a flu season coming up and a flu shot, has there been any discussion, and perhaps there hasn't been any discussion since January, it's an easy answer for you, but has there been any discussion on the pharmacist's capability to provide that vaccine and be properly compensated for it, if in fact we do end up with a vaccine? Because I'm assuming it will be expedited very quickly across the country, and I'm just wondering if pharmacists have any involvement in that discussion with the province.
Yes, well, I've certainly been pushing since April. Trying to get ahead of this bus. Everyone can see where it's going, and we have to make sure that we are prepared. So that was a big one, and I did bring that back to contacting government in concert with our regulatory body. A problem that I have with our regulations, the way they're written right now, is that we seem to be handcuffed by lists. So they say pharmacists can administer this, 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 and this. Well, or pharmacists can assess for this, 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 and this. And I've been long advocating, as new best practices occur, as new things such as a COVID-19 vaccine come, we're being handcuffed by a list. Why can't we just say pharmacists can provide adult immunizations, for example, or immunizations in that matter to anyone as applicable? But we are limited by lists. So at the time I was told that in a state of emergency they may be able to say that pharmacists can administer, and I'm not sure what the legalities are behind that. Regardless, you're absolutely right. Something like this sparks up. We should be prepared. We shouldn't have to go back for an emergency allowance. Pharmacists are certified to administer vaccinations and have been doing so very successfully, and this getting rid of lists would certainly go a long way in enabling that. The other thing that happened, unfortunately, and I forget whether it was I think it was 2 summers ago now, regulations changed that got rid of pharmacists' ability to order and interpret lab tests. And also to provide point-of-care testing is a problem, because they decided they were going to add lists to that as well. So simple things like helping a patient doing a blood glucose check in the pharmacy, for example. For a while, due to regulated words in the regulation, we weren't allowed to do some of these things that we'd always done before. And now we're just limited to about a list of 3 things that they're allowing. So in Alberta, for example, you may have heard COVID testing has been hugely embraced by that province, and pharmacists are doing a lot of it. We can't do that here because we are limited by lists.
The final question, quick one.
Just the other thing I want to talk about, the ailments you talked about earlier in your presentation, and I don't, like, just, can you give me just a ballpark of how many ailments, for example, that a pharmacist can actually apply their skills to presently under the present legislation?
30. Yeah, 30, and that's been in place since 2014. But as you know, best practices change, and we see, you know, things like shingles are very, very common. We can't assess and prescribe for shingles in this province, although in another province they can. We all go to the same universities. We all take the same assessment, patient assessment skills, and you know, there's no reason why pharmacists cannot be doing some of these things. Yeah.
Just a quick question. It must be, when you watch Nova Scotia, and you had 5 points there, where they invested in pharmacies, the 90-day supply PPE, virtual care, which we talked about, remove policy on smoking, and fair reimbursement. These are all things that Nova Scotia did. What was that like as an association to watch them moving forward and Prince Edward Island staying still?
It's very frustrating. It's extremely frustrating. And, you know, pharmacists, as I said, they were already feeling, you know, that they were putting themselves out there, being the ones that were facing this pandemic heads on, dealing with everything from phone calls to concerns to screening. We're doing all that, and we never shut our doors. We stayed there. And to have, you know, to see other jurisdictions say, yes, we acknowledge the impact that you're having to fill these gaps. We need all of our healthcare professions involved in this fight against COVID-19. And we are going to reimburse you to make sure that you can sustain that level of care for your patients. That's what we were asking for, and that conversation was not entertained. And it was extremely disheartening, not only for myself as an association executive director, but as a pharmacist. And I had phone calls from practicing pharmacists just like wondering what is going on. I'm exhausted, I'm doing this, and there's no even interest in entertaining any kind of discussion on reimbursement for what we're actually doing out there.
So when they were progressing forward, Nova Scotia and probably New Brunswick, you mentioned emailing the province. You would have been corresponding with them and letting them know that other regions within the bubble are moving forward. Yeah. What was your correspondence like from the province? So
essentially my messaging was consistent and probably frantic by times, but it was basically addressing some of the points that I've raised. And it's basically, you know, this is what we're doing. We really, in order to maintain this, we need to be able to be reimbursed so that we can pay. We can't expect our pharmacists to be volunteering their times, and we can't expect pharmacy owners to have staff in there doing a bunch of things that they're not reimbursed. There's no reimbursement model for it. Just that business model does not work. And this is what our skill set was being asked to do, and we absolutely were there to do it and wanted to do it, but we needed to have that reimbursement in place going forward in particular. So going forward, you know, we can better resource. We can ensure that we do have those support systems in place. But, you know, it's not sustainable for pharmacists to say, okay, if this second wave comes, we're going to have to, you know, get some extra support staff. We have them trained. We're going to have to change the procedures. We're going to have to do this in a different manner without any kind of an inkling about what kind of support you're going to have. And that's why we said we needed to know yesterday. We needed to know back in April how we were going to be supported going through the first wave, but then especially now during the second wave. And it's even more poignant as we prepare for flu season, because there are, and I'll show you in a moment, there are innumerable considerations that are going to be in play this season that are going to, you know, necessitate a huge change to the way things were provided before. And pharmacies can't invest in some of the investments they might need to unless they know that they are going to, you know, they can't provide the service and lose money on it. You know, to be quite frank, they have to know what they're dealing with when they're putting their plans in place. And you know, to the point that was just raised about maybe getting the flu shot a little early this year, we're hearing now that any time after September 15th, we may have it in the province. Typically, we waited until the first Tuesday after Thanksgiving to begin immunizations, and there was a good reason for that. Everything is decided, and I have every faith in Dr. Morrison's decisions on risk versus benefit. So if you immunize too early, the risk of coming in contact with the flu early fall is minimal, but the risk of some of that immunity perhaps waning at the end of the season is possible. So they've kind of found that sweet spot of when it was available versus when we could start getting it into people's arms before flu season really took hold. That has worked well. But in the face of COVID, that has to change, and having that vaccine available as soon as possible is going to be crucial, because we don't want people, first of all, if we get a second wave and we have community spread, we can't have people lined up on top of each other trying to get vaccinated. We have to get this done now while we have a little bit of a window of a reprieve. And we want everybody to be immunized, because if you got the flu, then all of a sudden you're one more person that has to go and get screened and tested, because the symptoms are very similar to each other. So we have to do whatever we can to prevent any extra strain or stressors on both testing and on healthcare.
Interesting, very, very good answer. A good pharmacy joke in there too, in people's arms. Anyway, we'll let you keep going
Sure.
with the presentation.
So some of this we may have touched on, but I'll just say that COVID-19 second wave and influenza are predicted to coincide. And as I said, influenza vaccination is extremely important all the time, but especially now, to minimize the number of people looking for screening, testing, and also those that may become ill. Based on a lot of, and we've been working on this as pharmacists since January, February, March, whenever some of our other colleagues in Australia, for example, in the Southern Hemisphere, are dealing with flu before our season hits here. And we do that every year, but this year is quite interesting because they cited approximately a 25% increase in demand for flu shots, and we don't see any reason why that would be any different here. Canada did do some surveys and so on, and that is reflective of what people are saying here as well. We know public health nursing, physicians' offices, and pharmacists were the three community immunizers for the provincial immunization program for influenza. And pharmacists, and I don't have the stats for this year yet because the Chief Public Health Office has been a little bit tied up, but basically the 2019-2020 year showed pharmacists gave 52% of all flu shots in the province. That includes the ones that were occurring in hospital and so on, and over 60% of those that were given in hospital, so more than all the other immunizers combined. We do know that because of public health nursing being redeployed, the clinics that people used to go to, for example, held in community centers and so on that were hosted by public health nursing, will not be offered in the same manner, and they just can't. And we also know that the mandated safety precautions, such as physical distancing and capacity, depending on your square footage in any location, are going to necessitate operational changes. So we may have to see some pharmacies moving to more appointment-based models to try to keep people from all flocking to the site at the same time. And there are going to be increased costs to deliver influenza vaccination services. A comprehensive proposal was provided to the Department of Health and Wellness on the 10th of July. We said that this is very urgent because people need to know what to expect when they're planning for their path forward. And unfortunately, we weren't able to get a meeting with the minister on any of this until the 24th of August. At that meeting, we were told that, I said, I cannot overemphasize how important this is and how time-sensitive this is, because people are trying to make their plans now, and was told that we would be hearing back. Sadly, we have not heard back to date what the plan will be. I'm very hopeful that we're going to hear something very, very soon. So to achieve the best possible outcomes for islanders in a safe, effective, and efficient manner, pharmacies must adapt their usual vaccination procedures, to ensure physical distancing, to ensure the appropriate level of PPE for patient and staff. We've been doing a lot of work nationally, looking at best practices from around the world, but also, tracking the virus itself. And, one time, is it large droplets, is it small droplets? So the PPE recommendations and requirements are evergreen, but we do want to make sure that we're providing the appropriate level to keep both patients and staff safe. We need to comply with the CPHO capacity restrictions, and especially in light of the projected increased demand for the service. We can't do like we used to do and maybe get 8 people through in an hour because they're lined up side by side and one after the other, and put them through in that kind of a quick fashion. Extra precautions are really going to increase the amount of time that is going to need to be spent with each patient. It was estimated to be at least a minimum of 6 minutes, and that was some work done in Quebec. We also need to maximize paperless information gathering. We don't like to be passing around pens and paper and that type of thing, so we're going to try to do as much of that virtually or over the phone or before the patient actually presents. And it certainly employ heightened sanitation measures between patients. So between each patient, the whole entire area has to be completely sanitized and wiped down. So we're looking at probably going from 8 immunizations an hour to probably 4 if we're on our best game. So the cost to deliver the service will increase due to many factors, and it's really going to depend on the model that each pharmacy employs to make best use of their space and of their staff and of the numbers that they're typically used to dealing with. There's the increased PPE requirements, increased support staff, so we're going to need somebody to be doing pre-screening before they come to the pharmacy and again upon arrival at the pharmacy. There's going to have to be crowd control, distancing instructions to make sure that 6-foot distance is maintained among those coming to be vaccinated. Appointment scheduling may have to be implemented in certain pharmacies. Some pharmacies may need to look at renting another venue if they have a small venue and cramped location, getting chairs that can be wiped down with alcohol and sanitized safely. Some are looking to invest in software for appointment scheduling, especially some of the more busy pharmacies. We need someone to help monitor a mandatory 15-minute post-vaccination wait time, and that may look different this year. It may be that we have to ask you to wait in your car because we don't have the capacity to have people waiting for the 15 minutes after. Some places in the south were lucky enough to be able to set up tents and do things like that outside, but October, November in PEI is not likely to be conducive to that type of delivery. And there's even talk of some places who have implemented drive-through service, so actually immunizing people in their car. But obviously we're going to need to have extra staff on hand to manage that. So that proposal that went to the department on July 10th, we did ask for an increased immunization fee to reflect a COVID premium to offset some of those increased costs. We also asked that PPE be supplied specific to that program through provincial procurement. We feel that the government probably gets a much better price on some of the stuff that we could and has a more reliable supply than we do. And certainly this is a provincial program that's being rolled out, so we felt it was fair to ask for that to be added to kind of the supports that we will require to provide a safe and effective, comprehensive influenza vaccination program as the primary administrator of vaccine this year. And also, we've been looking to get removal of billing barriers to comply with NACI, which is the National Advisory Committee on Immunization, best practice guidelines. And just, again, I'm here representing pharmacists and pharmacies. So as a professional, a healthcare professional, the recommendation is that if you're giving somebody an influenza vaccine and you have them there, it's the prime opportunity to make sure that their other vaccines are up to date. So pneumococcal vaccine, for example, and we do need strategies to increase our adult vaccination rates. We do a great job with children in this province, but the adult vaccination rates need to increase. I know CPHO has had several projects on the go to address that now obviously have taken a bit of a back seat due to COVID-19. But pneumococcal vaccine, for example, I can offer it to a patient who comes in at the same time and make sure that they're protected. but they'd have to pay out of pocket for that service because I can't bill the province. Yet if they were doing that at a public health nursing location, they could get it free of charge. So some of these barriers need to change. The other thing that has to change, in the early years of providing flu shots, we could provide flu shots to the non-health PEI healthcare holders because we want it to be a universal program. And particularly where I saw this the most, at the time I was working at a pharmacy out by the UPEI, and those students often don't have PEI health cards, but they're living on top of each other in cramped quarters. They're just a breeding ground for these types of things. And we were able to provide the flu shot to them and bill manually for that because we couldn't bill the system through their health card. The following year, we were told that was not going to continue. And we have been asking ever since to see that because we've seen people falling through the cracks due to lack of access. Now it's going to be even worse because they're not going to be able to have those other options. So we have asked for that to be lifted as well. And, you know, we may not have as many people in residence, but we certainly have a lot. And it just takes one to start the ball rolling in some of these cramped quarters. So I guess in conclusion, COVID-19 has served to illustrate the importance of making full use of the education and skills of all healthcare professionals. And never has it been more evident that pharmacists provide an essential healthcare service and could build capacity within that healthcare system. But fair remuneration must be provided for pharmacist-delivered services if pharmacies are to remain viable. We have an opportunity right now, I think, to modernize the delivery of healthcare services in this province, making full use of existing human resources, and that will improve access to care for islanders. And we saw how quickly, you know, we can mobilize change to enable virtual care, for example, platforms for the physicians, and developing online billing codes, you know, very, very quickly to make sure that those gaps were filled from that angle. There's no reason why we can't do a deep dive into what are the barriers, let's address them, and let's figure this out.
Great presentation. We have a number of questions after that. So we'll start off with Trish.
Thank you, Chair. So when Dr. Morrison presented to this committee last week, she told us that we could be looking at the end of September, or we could expect the end of September to start administering flu vaccinations here, PEI, and I have to be honest, I'm shocked to hear that there's been no coordination with pharmacists on how this is going to work.
And to be completely fair, busy as she is, I was able to meet with Dr. Heather Morrison twice during the summer. And as far as the principles of what product is going to be available, who's going to be eligible, and all those clinical details, she was very forthcoming, and she, you know, that's not the holdup. The holdup is how do we get this on the ground running? How do we implement the procedures that are going to have to be in place? And to do that and to make a firm plan and to allow for essential staffing, even if it's not extra pharmacists, if it's support staff that can help manage some of these new procedures, we need to know what we're dealing with. We need to know what kind of support is going to be there. I contacted every pharmacy on the island to find out, you know, what are your concerns? Are you going to offer the flu vaccine this year? And as healthcare professionals, it's we have to offer a flu shot to our patients. But there were some that were like, I just don't know how I'm going to make it work. And you know, especially some of them in rural areas, I'm concerned about because they have valid concerns, and you know, this one owner indicated that, you know, she can't do it at the risk of not being able to keep her doors open to serve the rest of the public because she can't, you know, afford to implement the service.
Trish, I'm not sure that was we didn't even get through your first question.
No, that was, thank you so much for that clarification. So this is a situation where, Dr. Morrison has done her job and she's ready to go from her perspective, but there's not been that next step of how will this be implemented, how will pharmacists be supported under these, you know, challenging conditions, very challenging with COVID, to actually move this forward. And, it's September 9th today. So I think one thing that we all recognize is that the early stages of this pandemic, this was a new challenge that we were all facing, that things were implemented quickly, and the response had to happen quickly. So, I think there was some leniency there. But in this case, you gave them a plan July 10th. You provided government with a proposal, and you've not yet had a response. And we're talking about a few weeks away now. I'm very surprised to hear that. I guess that's not a question. I'm wondering how will pharmacists be able to prepare for this? I mean, you won't have time. You'll need additional staffing, additional resources. What will you do if you don't hear back from government?
So what I've been doing is combing the best practices from across the country and giving suggested tips, different ways things might work. These are things that have been tried in other jurisdictions. Our national body, the Canadian Pharmacists Association, has worked with us in the provinces to develop a best practices guideline that's being released tomorrow. And it also will have a webinar which actually anyone of the public or in government can watch to see some of the challenges firsthand and some of the ways that people are getting around it and implementing in planning for their implementation of their influenza vaccination programs. I guess just letting people know that these are some of the things people are looking at as far as proceduralizing things, but we really need to know what kind of supports are there so that they can know which option they can make best use of in their pharmacies. And I'm hopeful that, I was very, very impressed and proud of our profession on how quickly they turned on that dime to make things work. I mean, they didn't, miss a step, really. People did not go without care. They're a pretty resilient bunch, but they're tired and they need help and they need to feel appreciated and not just, thanks for what you do. I mean, that's lovely too, but certainly they need to know that their contributions are valued and that they're supported going forward.
I do want to ask just one more question. I know others have questions as well, you had mentioned before we went to the discussion of the flu shots about COVID testing and the fact that in Alberta, pharmacists are now administering, I believe it's asymptomatic testing actually, for COVID-19 tests. I was wondering if you could speak a bit more about that, if that is something that you think could happen here in Prince Edward Island, and what some of the benefits might be of expanding out to allow pharmacists to be able to do that as well.
And we'll follow the best practice recommendations from Dr. Morrison, and if we get to the point where they feel that testing needs to be increased, and we don't know what's going to happen with now that we have students all in the school system, we have some of our foreign workers coming and having showing signs of infection. We don't know when or if community spread is going to occur, but I think we have to prepare that there's no reason why it wouldn't here if it does everywhere else, right? So as far as that goes, currently we're not able to provide certain point of care testing. That isn't on our list, so it wouldn't be something that we could do. It would require some change. Another great reason to get rid of lists, and we've been saying that forever, that there's no need to have lists. Pharmacists are either skilled to do assessments, skilled to give injections, skilled to do point of care testing and interpreting those results or referring those results, or they're not. So we don't need a list attached. And I think that's the first step, is to make sure that these things the regulations are modernized and let the self-regulating profession of pharmacy self-regulate.
Okay, and I want to just add, so we did recently see an opening of drop-in testing centers here in Prince Edward Island, which I think is good that we're expanding our capability or capacity for testing, but that still is only available in certain locations, so O'Leary, Summerside, Borden, Charlottetown, and in Montague, and when I think about the reach that pharmacies could have, as you mentioned, I think you said 49 or different locations where this could across the island. I'm thinking about all those parents who are now, going to be in a situation where their child might need to be tested because they are showing some symptoms and they get sent home from school, and just the increased capacity that we're going to face over the next, especially with schools opening up. It seems like something that I hope has been considered, and I would like to know, perhaps why. Not that you have the answers, but why we're not heading down that route as well, to really open up that capacity to make it as accessible as possible for people. So that's, I guess, not a question for you, but perhaps a follow-up question for the committee. So that's all. Thank you.
Thanks, Trish. Heath?
Yeah, just, I mean, we're in unprecedented times, obviously, and we've seen it in mental health, and obviously, and it's COVID's certainly putting a lens on several different aspects of our society socially, and the barriers and impediments or things that maybe we never paid as close attention to as we should have. And I know the member sitting behind me has voiced his concerns relevant to some of the issues that you presented, but there's one thing in here that I think everybody would agree with, and if I'm wrong, I'm wrong, but communication, with an association as important as yours, and not being able to access a department for relevant information or discussion is mind-boggling as an MLA and a former minister. And I know ministers sitting in here, there would be no problem going through the front door and saying, having a meeting. And I find that, I know you met with Dr. Heather Morrison, who obviously is likely the most busiest person on Prince Edward Island. So I'm kind of concerned or confused by that meeting has not been set. Some of those discussions have not been made. And
so the meeting took place on August 24th, but the request was put in writing at the beginning of July, and on July 9th. So we did have a meeting, but we've not heard any follow-up. We were told we'd hear back in 7 to 10 days, and we haven't heard anything.
And that was relevant to the flu shots and the vaccinations, which.
Yeah.
Heath? Okay.
And in fairness, as I said before, I wanted to know what the barriers are because of, the circular conversations that have been going on since 2012. The he said, she said type of feeling. If we get everyone in the room, we can figure out where the barriers are, address them, and move forward. So I was quite pleased to meet with the deputy minister on a couple of occasions with that group. Now, since January, there's been no movement on that, and certainly COVID took place. But again, I think, as I mentioned, we have such an opportunity here to look at what the issues are. They've been, illuminated. I think very obviously to everyone that there are gaps, there are people out there that can fill these gaps. Why aren't they, and how can we make this work?
Perfect. Sydney?
Thank you so much for your presentation, Erin, for over the years and your hard work, and I appreciate all the work that your association has done during COVID as well. I understand, you're doing a great job for the provincial lobby, for the pharmacists and the pharmacies, and sometimes there's a rap there of big money, with the big companies that are owning pharmacies, and I get very frustrated because I look at it through a different lens, as you know, and you mentioned the pharmacy in Morel, which is not unlike many of our rural pharmacies, and they don't rely on all the extras that large pharmacies, which you fairly represent as well, that come in, that extra cream that comes in the door, that all those extra sales and stuff, right? They're there simply as our primary healthcare provider. Yes, I'm biased towards Morel. That's, the pharmacist there, that is the healthcare provider in that area, like immediately, right? We have wonderful physicians that we leave the community for, but it's right there. It's huge for community development. The councils, not just Morel, but the surrounding communities all rely on that, and they're not simply, the pharmacists, they're simply not reimbursed for the services that they provide because it's advice, it's all too well. I won't continue on this narrative, and we know about the generic drug cost is good for a consumer, but you've explained this many times in committees like this and meetings before, but how that reduces profits for a pharmacy, and in a large setting it's not as noticeable, but when you're in a small setting like Surrey or Morel or Montague, it is noticeable to the bottom line, and keeping those pharmacies there is so critical for our communities. I have done the same, like many members here, trying to pressure behind the scenes as well for changes. I looked at legislative changes and realized that the list that you speak of is actually in regulations and can be changed at any given week. From your perspective and from your conversations, and I understand that it started getting somewhere earlier in this year for sure. If those regulations were changed as far as prescribing for pharmacists, and you speak about the 30 things, if that was modified, does that inversely affect anything else? And I don't mean negatively financially for physicians or anything like that. I don't mean like that. Does it, if that regulations was simply changed, can we have multiple groups of people prescribing? Like would it cross other pieces of legislation or other regulations from your opinion?
Well, I mean, certainly there are, there's scope overlap. And as far as what prevents one provider from doing rather than the other, I'm not an expert in other people's legislation, so I'm not sure what would need to be tweaked or addressed, but I'm sure it's not unsurmountable. Jurisdictions such as one in Ireland, in the UK, realized that people were going to see their GP for cold sores and for various common ailments, perhaps contraception, things that don't need a thorough investigative diagnosis. That's not my forte. That's a physician's forte when it requires a thorough investigative diagnosis. For some of these common ailments, or for that matter, if a woman presents and requires contraception, that does not require a diagnosis. That requires someone who is an expert in the drug treatments, in the options available, that can prescribe it, contraindications, the whole piece, to make sure it's the right product for that person. In the UK, in this particular jurisdiction, they mandated people to go through their pharmacy first because they couldn't afford to have, the physician was overqualified to providing the level of service that was required for some of these cases. And to be frank, they could do it a lot less expensive in a pharmacy environment. So that's been going on there for a while. There's different models that are starting to adopt. There's expansion of scope, like I said, in Alberta since 2008. There's been no, catastrophic event since pharmacists started doing these things in Alberta, and patients have all the trust and the faith in their pharmacists as they always have.
Sydney?
Thank you for that, and I appreciate your comments about when everything else shut down and the pharmacists kept going. It's like Hannah mentioned, all kinds of things changed in the pandemic, and you realize, oh wait, they can actually do that because you were providing that advice, and as the vast majority of us go into a pharmacy and just ask questions and don't realize that technically we should be charged for that, right? And it's an uncharged service. So I commit to you to keep up the lobby. Thank you.
Great. Hannah?
Thank you, Chair. So probably a little less subtle than some of my colleagues. I'm frankly really disappointed on your behalf that this is such a struggle. I again appreciate that you are continuing to show up and be professional, and that your colleagues are. But this is incredibly frustrating, just for the short period that we're sitting here talking about it. So I can't imagine what it's like to have to do this every day and keep showing up for work. So thank you. But I'm hearing there's 2 or 3 different pieces in here. There's an immediate need to get a response on the proposal that you've submitted because we are barreling into the flu season, and I would ask the chair that we consider putting something in writing from this committee to formally request that the minister respond, and that he responds positively to that proposal, because we literally have a matter of days, not weeks, before flu season begins. I think that following on from that is then to continue this discussion around that expansion of scope of practice for the emergency and immediate healthcare needs, which have only been highlighted through COVID. One of the questions I have relating to that, and unfortunately I think I know what the answer is, but I'm going to ask anyway, is have you had any discussion or consultation with the Department of Social Development and Housing around providing services, including flu vaccinations, for vulnerable populations?
No, we have not. Although I did raise the issue with my college to about where am I limited through regulation. So for example, I, before COVID, had a regular shift at the soup kitchen, for example, every week. Could I go in there and be within my practice directives and scope of practice off-site, not connected to a pharmacy to administer flu vaccinations? And so long as I'm, I have to have my required emergency preparedness kit and maintain cold chain and follow all the regular standards of care, the actual location is not of concern. So there certainly are ways to make these things work.
Yeah. Hannah?
Thank you. Following on from that, I know you mentioned earlier about restrictions and particularly around sort of the reimbursement, is it's connected to sort of health card record. And so, a couple of the other populations that I'm thinking of that are potentially risk populations as we go into the double whammy, flu and COVID, are newcomers and temporary foreign workers, and our university populations who I know, even though there are less this year, we still have a population of students who are here who may not have a PEI health card. And so is there any provision within the current regulations to allow for vaccinations to be provided to those populations?
And that's not a regulatory issue, that's a policy issue.
Okay.
So it's just a matter of saying, yes, you can do it again. Initially, we were told that it was a matter of, receiving these faxes and so on wasn't conducive to how things should be managed. And then there was some discussion about the mandate of the provincial drug programs and whether that should be extended beyond provincial drug program recipients or healthcare card holders. But again, the first year it worked like a charm, so I'm sure there's ways that policy could be amended to make it work.
Yeah.
Yeah, thank you, Chair. And again, I'm thinking about this in terms of sort of where our potential risk spaces, our risk vectors are where there's a higher likelihood and impact from or potential for community spread, which is obviously what we're trying to avoid, and the pressures that could come from that double space of the vaccination. Now, you'd also spoken about sort of senior populations. Was part of your proposal to provide any on-site vaccinations for things like long-term care homes, or is that handled in a separate part of the administration? So
they have currently, any place that has nursing staff, they do have people on site that can administer. So that's traditionally the way things have gone in care homes and so on. Some of the options that we did ask about were, for example, there's a policy in place now that if you wanted to go to an on-site employer environment, can we do that? We certainly can, but you can't build government for the administration in a workplace. And the reason for that is they feel that it is, that was always, before they went to a universal model, that responsibility to administer and for the convenience of not having your staff lose work time and so on was assumed by the health and safety policies within that work site. So that was something that we raised. We said, given the fact that we may be, real estate may be at a premium to keep people socially distanced, and being able to take the vaccine to the site, could that be something that could be looked at to waive that responsibility of the employer? Because some smaller employers may just say, well, we can't afford to hire someone to come in and give vaccines. Everyone go to the pharmacy. So we asked that question, and I'm not sure where that's going to land.
Yeah, so Chair, perhaps
Anna?
later, thank you, Chair, we'll make that motion later, but
Yeah.
for now, that's the end of my questions. Thank you very much.
Suggesting Jamie?
Chair, thanks very much for coming in today, Erin. Something I've always wondered about for the longest while is why we do not do more things at pharmacies. And I think that it is a way to look into the future when we can consider that. Your presentation is very informative, and there's a lot of information here to develop, so thank you very much for that. But I'd like to ask your opinion on something. I'd like to actually hear from the regulatory body also, from the College of Pharmacists. And do you think that would be a good next step if we had the college in to have a lesson?
You know, and I have been in communication with the college as well on a lot of these issues. And, you know, there was some, I don't know, I was interviewed by CBC a while ago now, I forget, it was pre-pandemic, about some of the things that we were looking to get implemented, some of the changes we needed as far as regulations go. And the question was put, you know, well, why isn't this moving forward? And at that point I said, well, you know, I'm trying to get the conversation going to find out what those barriers are so we can remove them and move forward. And at the time, you know, I said, speak to the college and see, you know, what their perspective may be on this. At the time, the college said, you know, we were basically working with government to see what works best within their planning, what services are more required, where their priorities are before we move on some of this stuff, which my members were quite disappointed to hear. As an independent profession, you know, we certainly know, we see firsthand the gaps. We see, you know, when someone comes in and they need these 4 vaccinations provided, I can only give 3 of them, and by the way, I can't give to this person because they're under my age limit. Some of those things that are, you know, when you're rolling out some of these services, you see where the gaps are, you can identify them. You know it's within your scope to offer the service, but you can't. So those are the, I think listening to the pharmacists on the front lines and pushing forward, I think that gives you a really good picture about what's lacking, where the gaps are, and where we see that we can improve things. I find that you know, our college is small, and it's a bit maybe more conservative than some of the other colleges that may have more staff that are at their disposal to consider some of these things. And moving forward with recommendations and so on is dependent on size and staff as well.
Jamie?
Okay, thanks very much for that, Erin. I would ask then, Chair, that in new business, I'll be bringing that motion forward.
Sure.
Thank you.
Sure, thank you. I just have a couple little questions, and then we'll see. Would your members be comfortable, I mean, it's a hypothetical because it's not here, administering a COVID vaccine whenever one is made available?
Yes.
What are your thoughts on making vaccines mandatory amongst healthcare workers and within the public schools branch?
So if you read the NACI guidelines for immunizers, and that's kind of like our immunization Bible, it's best practices and it's expert reviewed, and I'm sure Dr. Heather Morrison has contributed to it. But it is, the NACI guidelines is basically what dictates best practices for immunization for any immunizer, be it a nurse, pharmacist, physician, whoever. And they have made a strong recommendation. Now, they've not gone so far as to mandate, because that's not their mandate to make things mandatory, but certainly they say healthcare professionals, best practice, you get immunized. As far as, you know, the epidemiology and that type of you know, decision within the public schools branch, that one I would probably leave for Dr. Morrison. She's, you know, she's the expert in that realm for sure.
I just want to go back. I think we've covered. We have a good plan of attack as a committee to, you know, help you know, make it easier for you or push some things forward. But you mentioned before the 811 calls not being returned. Mm-hmm. Is that something you saw a lot of? Was it prevalent with clients coming in to see you?
It was fairly common, yes. There was particularly a time when you couldn't get through the lines, and I think you recall that, and you know, they did, I don't know whether they increased capacity or what they did, but there were definitely some gaps there and some challenges. But prior to all of this, this was back in, I don't know whether it was 2010, we had the conversation with government about, you know, pharmacists being that resource in the community. We are the ones that they're coming to for these questions. We are the ones that are providing triage and that type of a service. And we are fielding an awful lot of phone calls, especially after hours. And there was one particular pharmacy that used to be open till midnight that, you know, was just being inundated with calls. They were the only game in town. And, you know, we asked, is there some sort of a, you know, of a reimbursement model for that, you know, to be that go-to person. And at the time, it was not entertained. And shortly thereafter, 811, which is another off-island service housed in Nova Scotia, was enlisted to do the very thing that we had suggested. So that type of thing has been a problem. And even prior to COVID, a lot of the times if you called 811 and you gave a particular scenario, there were so many times when we would get the call in the pharmacy and they said they told us to call our pharmacist and ask. And again, you're dealing with, it's the difference between going to Dr. Google and Googling what the answer is, and then going to someone who knows you and, not saying that 811 is Dr. Google, but you see what I'm saying. There's another layer to knowing that patient, knowing the complete picture and having a little bit more information at your disposal. I think you give more sound advice. And if it's something that, can't be managed at a pharmacy level, then that patient is referred.
Excellent. If you had 3 or 4 final things to tell this committee, because we're doing a report in the Legislative Assembly in November, what would they be? And as well, 2 or 3 things that we would put in a letter to the department, what would you put in those?
I think that, the big message is we have been given an opportunity now, maybe a brief reprieve, to really take a peek at what has happened and how we can move forward using all the healthcare professional resources, human resources that we have access to meet the demands that have only increased with COVID, but even pre-COVID. We've been hearing about, lack of access to a family physician, wait times at clinics, people using emergency rooms for purposes other than urgent care. So I think utilizing pharmacists as part of the primary health care model is definitely at the top of that list. And in that, if you're going to invest in capacity, you have to invest in capacity so that that pharmacist can expand their offerings within that pharmacy and be paid to do so. Because a pharmacy owner can't expand their staff to meet the demands of healthcare service if there's no reimbursement model for it. So we maintain that a covered service, if it's something that should be covered by government, and we're a healthcare provider within that framework, it should be covered whether it's a pharmacist administering that pneumococcal vaccine or whether it's the nurse. It makes no difference. And for the I guess the third, I think we would really like an opportunity to to collaborate and see where we can, identify these barriers, eliminate these barriers as much as possible, and move forward.
Perfect. Well, you did a wonderful job talking to the committee. Is the committee okay with leaving it? Okay. Great job. And what we'll do now is we'll take a 2-minute break, and we'll just allow you to leave the room, and then we'll come back and conclude the meeting. Okay, thank you. back after a recess to move on with the next section, which is new business. Can we do it on new business? Yeah, I think Hannah was up and then Jamie.
Thank you, Chair. As I mentioned in the earlier session, given the clear statements from our presenter, I would like to make a motion that we prepare a letter immediately to go to the Minister of Health, requesting that he action the proposal that was submitted by the Pharmacists Association on July 10th.
Okay. So there's a motion on the floor. Would anybody like to talk about that motion that was just presented? Is everybody okay with that? Okay, so. Oh, sure.
I didn't read it, I just made it up. I just said I would like to make a motion that we send a letter to the Minister of Health as soon as possible, as per the statement made by our presenter, that the actions requested in the proposal submitted in July 10th are acted on as quickly as possible. Mm-hmm. Something like that. Super urgent.
Sydney?
So they met on August 27th, right? And there will be a response back from 7 to 10 days after the 27th? 24th. Sorry, I wrote down. The 24th. Anyway, yeah. You're right, the 24th.
The proposal was submitted in writing on July 10th.
No,
yeah.
Sydney? Yeah. Oh, sorry. Oh, you're done?
Yeah, no, okay. I was just saying, so the proposal was submitted the 10th, they met on it the 24th, and the minister said that they'd be back in 7 to 10 days, and I agree with the motion.
Okay, perfect. Anybody else? Jamie?
Chair, I'll play devil's advocate here. I'm wondering maybe in the letter, we should also signal maybe that maybe they are actually working on it, and maybe they just haven't got it out yet. So maybe that wording could be in there that, you know, we understand that this is busy times maybe, and that you know, can you provide, do action it, but can you provide an explanation, you know, maybe it's in the works.
Yeah. Right? Okay, so then we'll put that in there, something along those lines. Obviously, we'll send it, we'll let the committee see it maybe tomorrow. We'll send it out tomorrow. So once we do get that letter back, I would ask to get the information back as quickly as we can. If we don't hear back from you by the end of business day tomorrow on the letter, we would send it. So any updates there? So that motion will pass, and then your feedback will be important tomorrow if you do get that. Okay. Jamie, did you have other new business?
Yes, thanks, Chair. I'd like to make a motion or suggest that we ask the regulatory body, the College of Pharmacists, to come in and to meet with us on some of the points that she raised and have that chat.
Sure. Perfect. So, Trish?
Just a suggestion, do we want them to necessarily, like, do they have to come in, or can they give us a written submission? Do you?
No, I'll let them come in.
Okay, that's fine by me.
Okay, so we'll check with the clerk on that. We'll draft that letter. We are pretty full, so I don't know if that becomes a time-sensitive situation. Jamie?
I'd almost wonder, Chair, if it would be time-sensitive, because, you know, where we're hearing from Erin, and we have concerns that they have met with, you know, the minister, and they're waiting for a response to going forward. But we should also know that, you know, is there things that the college we should be doing now that could tie in? Like, if we say, prime example would be if anything to do with vaccinations, right, or whatever. Well, maybe we need to hear from the college, well, if we want to do these vaccinations, maybe we can't do it because there's a problem with the regulations or the acts. So,
sure.
Can I make a suggestion?
Yes, Trish?
So just since the schedule is quite full, can we invite them to come and present, and also let them know if they'd like to submit something to us right away in writing if they have immediate concerns about those things, that we will consider it immediately? Like, would that be good?
it'd be good background or information, Trish, too.
Yeah, just
It's a
so
great
we don't
suggestion.
delay, because time is short.
So we will do that, and that just might be a double booking later on if we can get them in the end of September, October. So perfect.
I will say too that I recently heard from the group we had in coming on to speak on recruitment and retention, and they're looking to now reschedule for sometime in October. So we do have a little bit more flexibility now in the schedule if we want to prioritize that.
Okay, okay, perfect. So we'll try to get that letter out tomorrow, and potentially we'll get the clerk to touch base with them verbally and see if we can speed that process up. Perfect. Trish?
Thank you, Chair. So the Maple virtual app, so I've had a few questions about this. I actually submitted some written questions, have not had a response. And this just opens up more questions for me about this app. We don't really know very much about it, about what the capacity is, you know, what can it actually achieve, what can the doctors do through the app, and I think, you know, the questions that were brought forward today about compared to what pharmacists can do within their scope of practice and what the virtual app allows, you know, to get done, like there seems to be a lot of overlap there. So I mean, this can be doesn't have to come and be a presentation, again, because I know our time is limited, but perhaps a letter to the Minister of Health asking for some clarification about what it is, you know, what is the scope of that can be achieved with the virtual care app. Are they able to see the current prescriptions of a patient or not? I'm not sure, because that was a really important part, I think, that Erin brought up, this de-prescribing job that pharmacists do, where they're you know, looking at the full list of prescriptions as they're hearing about, you know, different learning about the patient's history. And anyway, I know we're short on time, but I think it sounds like not only that there's overlap, but that pharmacists could actually do more. And I would like more clarification about what's possible with the virtual app, as well as I believe the contract ends March 2021. So what are the long-term plans where people who sign up for this app you know, have to pay for it themselves after March 2021? And are those people still on the wait list for doctors, or are they bumped off of it when they accept the app? So these are all questions that I have. Yeah. I don't know if people have other things to add to that letter, but
Definitely, and it could be. We'll put that letter. Is it all right if we did that in a letter?
I'd love a presentation, but again, within the realm of time and all the other things that are, you know.
Yeah. Thank you, Mr. Fox.
The realm of time.
Yeah.
That was a good way to put it, but you know what I mean.
Sorry, Claire. Clarification.
Just in his motion there, points that our last presenter made, you wanted the college to come in and speak kind of as an addition to that? Okay, I just wanted to clarify. Yeah.
I too think it's important with the Maple app that we received the letter, but I would also like to understand it's a new form of health delivery in Prince Edward Island. I think that this committee would well serve to get a briefing, so if we can arrange that for the future. I know we're getting busy, but I do believe it's COVID related, and I do think it's important. So we'll send the letter, and we might also, if the committee feels it's appropriate, to have somebody come in and talk about that
At a later date.
at a later date. Yeah, perfect. Okay. Anything else at this time? No. So just before we adjourn, the next meeting is September 16th, Health PEI Recruitment and Retention. Just got changed. September 30th, we have the Canadian Mental Health Association in that day. So we're working on the other dates. At this time, can I get a motion to adjourn? Hannah Bell. Meeting adjourned.